Then of course withdrawal of some stimulants like amphetamine or toxicity of amphetamine, both cases. Then as alcohol toxicity will produce seizures or withdrawal will produce seizure? Withdrawal will produce seizure. Then there can be metabolic diseases like hypocalcemia. Hypocalcemia can produce increased chances of firing by the central nervous system. Don't forget that calcium guards the sodium channels, and when there is less calcium, then sodium channels are not guarded and more sodium influx occur. Do you know that? Look, this is a sodium channel. It is having lot of calcium ions here, which prevent the overflow of sodium. Sodium is not unduly going in. If you develop hypocalcemia, this calcium will detach from here, and sodium channels will remain unguarded, and excessive sodium will go in, and hypocalcemia will lead to hyperexcitability, including the fits. Right? In the same way, hyponatremia. How the hyponatremia can produce seizure? Because when sodium concentration in the extracellular fluid is less, more water will go into neurons, the neurons will swell up, and swollen brain has a high chance to develop epileptic attack. Hypomagnesemia, calcium and magnesium work in the same way. Hypoglycemia, of course when glucose is less, ATP is less, sodium potassium ATPases are not working, neurons are overloaded with. Then renal failure. In renal failure, in acute renal failure, it's the rising potassium which disturbs the CNS, and in chronic renal failure, it is the nitrogenous products which are retained in the body like urea and creatinine and other, and which disturb the microenvironment of the central nervous system, and products of nitrogenous waste products retained in renal failure irritate the neurons. And of course, then you should not forget hepatic encephalopathy. You know, when liver is not working well, right, lot of toxic substances accumulate in central nervous system and irritate the neurons, right? Then some infective process can not only produce partial epilepsy, they can produce generalized epilepsy also, especially meningitis or encephalitis. Then inflammatory conditions which can lead to generalized epilepsy are again SLE. SLE can produce partial epilepsy as well as in some patients it can produce generalized epilepsy depending upon the vasculitic lesion is one or two or the many vasculitic lesions. Right? Then we can say certain degenerative diseases. Do you know some degenerative diseases in CNS? Yes, Alzheimer's disease. What happens in Alzheimer's? Yes, Dr. Aisha. What happens in Alzheimer's? Dementia. Dementia in Alzheimer's patient, he develops dementia. Patient loses recent memory. Patient loses the higher mental function, especially capability of intellectual thinking or abstract thinking. Alzheimer's disease. Then there is another disease which is called seizure disease. This is produced by which organism? Prions. Prions are, how do they multiply in your body? Have you heard of prions? You never heard of thing like this? Have you heard of mad cow disease? That is by prions. Prions are special infectious proteinaceous molecule. I will not go into detail of them right now, but once they enter into your central nervous system, they corrupt your own proteins and your own proteins start converting into prions. Prions are misfolded, beta plated of course you want to say it. Prions are misfolded proteinaceous molecules. When they enter into our neurons, they lead to our own proteins undergoing misfolding. They corrupt our proteins. So if one corrupt protein enters in our neuron, after some time your neurons may have millions of corrupt proteinaceous molecules. And eventually, brain with lot of such neurons loaded with prions will become soft. We call it spongiform encephalopathy. That's excellent. So in these patients also, there's a high chance to develop epileptic problems. Now we come to investigations. Few words about investigations. Investigations you have to do, number one, investigation to establish the diagnosis. Is there epilepsy or not? Of course, EEG will help, right? Then or video telemetry. Then investigations to find the structural lesions. Of course, you will talk about CT scan and MRI, in which CT scan is less sensitive, MRI is more sensitive, but another thing you have to remember, anyone who comes with seizure, CT scan or MRI should be done after first attack, right? Then you have to do investigation for other metabolic conditions and infectious conditions. Of course, there is no fun in telling that you will do serum electrolytes and you will be doing urine analysis, you will do urea and creatinine, you will do, yes, a liver function test, because you have to rule out other causes. You will do, of course, why don't you start with the simplest thing, blood complete examination. In blood complete examination, ESR should be done, hemoglobin should be done, yes, TLC, DLC should be done. So infections can be ruled out, right? Then there should be blood sugar, hypoglycemic attack should be ruled out. Then there should be, yes, urea, creatinine, then liver function test, and of course then calcium, magnesium, sodium, potassium should be done. And other, again, which investigations you will really do, it depends on the history and physical examination, which will dictate in which direction you must go. For example, on CT scan, if you find a mass in right hemisphere, then of course you will think of more structural causes, right? After, do you think chest X-ray has some role in that? Of course, if there's tuberculosis, secondly, if tumors in the chest may be giving secondaries to the brain, which is producing epileptic problem, secondaries in the brain, right? Of course, you will do serological study for treponema pallidum, or you will do for HIV. Do you think you need to do CSF studies? Yeah, maybe you will get clue to certain metabolic problem, or more importantly to the infective problem, right? So this is about the investigations. Again, I will repeat it. When a patient with seizure comes first time, we have to get EEG, we have to get CT scan and MRI if it is available. Then depending upon the history, you have to do all the screening for the electrolyte problems and renal failure and liver failure, and yes, for the drug screen, for example, some patient is taking some drugs properly or not. Then we can come to management of the patient with epilepsy, the last part. In this management, we have already discussed at least the management of status epilepticus, in which I missed one point. Who is going to tell me? I missed a very important point in the management of status epilepticus. I put the relatives in jail? No. Patient has come to you. You are in charge. We have gone like this. Put the patient into safe position, secure the airway, get the oxygen in, develop more than one IV lines, one dextrose free, because phenytoin should not be complex with dextrose. Then IV line, are you sure? In which you put diazepam bolus, then intravenous IV line, slow infusion of benzodiazepines. If both don't work, you go for loading by phenytoin and then slow maintenance of phenytoin. If unfortunately this also don't work, you go for phenobarbital. If that doesn't work, you go for barbiturate coma or propofol general anesthesia. We missed something extremely important. Especially, okay, I'll give you a hint. Especially if patient who is under status epilepticus looks as if he is alcoholic or malnourished. Yes, thiamine. We should give, Americans say 100 milligram thiamine and Britishers say 250 milligram thiamine should be given immediately, injected, and it may be followed by 50 ml of 50% glucose. Who will tell me why? Remember, maybe this status is due to hypoglycemia, and if you give heavy dose of glucose, 50 ml glucose with 50% concentration, not 5%, it is 50% glucose, 50 ml, then what should happen? Patient should immediately wake up. But why we give thiamine before that? Anyone? Yes, madam. Why we give thiamine before giving glucose? Internationally, this is a rule. When you suspect hypoglycemia severe, give what? 50%, 50 ml glucose, always first giving thiamine and then glucose. Why thiamine is supposed to be given?
Thiamine is required for glucose metabolism.
Yes, very good then.
It should be present before we give
Someone else. Why thiamine should be given? In America, if you give glucose, if a person who comes into fits or hypoglycemia, you give the glucose, patient just within 1 minute he will come to consciousness and talk to you happily, but he will go out and put a case against you, and maybe then you lose millions of dollars. Excellent, very good. Actually, if you have thiamine deficiency, which is more common in malnourished patient and in patient who suffer with alcoholic disease, thiamine is not absorbed well or not present in the body. When you give heavy dose of glucose, thiamine is required for glucose metabolism, and if thiamine is already very less in central nervous system and you have given high amount of glucose drag away that thiamine, severe deficiency of thiamine will precipitate demyelination of multiple tracts in central nervous system. Remember, thiamine has two functions. Number one, to play a role in glucose metabolism. The more important, it is also playing a role, yes, in maintenance of certain neurological circuits, right? Especially Pape's circuit. Do you know Pape's circuit? Hippocampal pathway, parahippocampus, hippocampal, then fornix, then fornico-mammillary, then mammillothalamic, then thalamus-cingulate. It will come into neuroanatomy. This is called Pape's circuit. This Pape's circuit is concerned with short-term memory. Right now, if you are registering my lecture, it is through the Pape's circuit. Small, recent memory. Is that right? Your Pape's circuits are working. These are what? Hippocampus, parahippocampus, in parahippocampus, hippocampus, then fornix, dipping into mammillary body, then mammillothalamic and thalamus-cingulate pathway. This is for the emotional memory and recent memory. Actually, what really happens? If you have deficiency of thiamine and I give you heavy dose of glucose, what already central nervous system has less thiamine, whatever is there, it goes to the glucose catabolic pathway. Neurons in Pape's circuit will undergo degeneration. Secondly, neurons which interconnect the third, fourth, sixth nuclei, they also undergo degeneration. So many brainstem nuclei, temporal lobe nuclei and Pape's circuit nuclei undergo degeneration. And this condition is called Wernicke's-Korsakoff syndrome. Wernicke's-Korsakoff syndrome. And if you have given some person who was in coma due to hypoglycemia or in fits during hypoglycemia, you give him heavy dose of glucose, he will come to the senses and put a case against you when he will not remember many things. Is that right? He will develop what problems? Wernicke's-Korsakoff syndrome, which is due to demyelination and degeneration of many neurons in central nervous system. That is why whenever you give heavy dose of glucose to someone, always give thiamine after that, before that, right? Anyway, let's come to the management of epilepsy. It's very simple. Once you have diagnosed a case of it, do you want a break for 5 minutes? Okay, ji, let's have a break. Now, management of epilepsy. Epilepsy. Now, when we talk about the management of epilepsy, first of all, once a diagnosis is made, most of the patients get upset, as the multiple reasons for that. The most important reason that it is socially stigmatized. Then I told you that diagnosis of epilepsy has implications on driving license, it has implications on your professional career, and it has implications related with the management, because you have to take the drugs for a long time. Now, the first thing is counseling of the patient, right? You have to explain the nature of the disease to the person, and you have to give certain advice to the patient. The advice which is important is number one, patient should not be involved in some dangerous machinery operation, right? Should not operate any dangerous machinery. And remember, one of the most dangerous machinery is car, automobiles, because if you get an attack during driving, you put your own life at risk as well as others, right? Number two, patient should not involve any activity, layer activities which are also dangerous, like swimming. If someone is swimming and gets attacked, maybe lost, right? Or mountaineering, or working on the high areas above the ground. Then patient should be told, especially in case of generalized epilepsy where consciousness may be lost, then patient should not use washroom with locked door, and preferably if some family member or near one is at home. It should be at home, right? Because if a patient gets attack of epilepsy during, you can say within washroom, maybe he is not, if no one is around, patient suffers a lot. Then patient should be advised to avoid the trigger factor. As I told you, in some patient epilepsy may be triggered by light, and some patients it may be triggered by sleep deprivation or from the noise. So different patients have different trigger factors. So from the history you decide what is the trigger factor for a particular patient, and patient should be advised to avoid those trigger factors, right? Then after that, you must console the patient, because patient has very first question that if you are going to put me on the drugs, what are the chances for me that on drugs I will be controlled? This is the patient's first question. If you are putting me on the drugs, what are the chances that drugs will work with me? And number two, patient has second question in his mind, how long I have to take the drugs? And as a good doctor, you have to answer these questions very honestly and straightforwardly. So what will be your answer? Who will tell me? Yes, Doctor. What will be your answer? If I'm a patient with epilepsy, right, and you are my doctor, I ask you that fine, you put me on the anti-epileptic drug therapy, what are my chances that these drugs will control my seizures, generally speaking? Is it 100%, 80%, 20%? Yeah, if a bad doctor is managing, it must be 50%. But good doctor must be around 80%. Right? So you don't horrify your patients. Right? Good doctor must tell that 80% of the patient who are on the drugs, they are having well-controlled seizures. Unfortunately, in 20% of the patient, even with the drugs, we cannot control them. I told you, when you have appropriately used different drugs and you cannot control epilepsy, you have to review your diagnosis. Is that right? You have to find the underlying cause. But anyway, the first question is, patient will ask you that what are my chances that if you're putting on drugs, what are my chances that my seizures will be controlled? So answer is about 80%, 70 to 80%, number one. Second question which patient asks, how long I have to take the drugs? Because taking drugs is not something pleasant. It is not food. Number two, many drugs have side effects. So patient has to make decision, not you. If patient says that he doesn't want to take drug, you cannot push the drug. Is that right? To his body. So you have to explain to the patient how long he has to take drugs. So what's your answer? How long a patient of epilepsy should take a drug, or he is going to take drugs?
Lifelong if it's idiopathic and symptomatic.
So she will again horrify the patient that patient has to take lifelong the drugs. Okay, she will really kill the patient. She says as soon as seizure will stop, we stop the drug, so he come back with more seizures. Right. Yeah, who is a good doctor here? There are standard practices all over the world. They say once you start the drug, it will take some time to start control the seizures. Once seizures are controlled, patient should have at least 2 to 3 years seizure free time. Patient should have 2 to 3 years of seizure free time. Then you may consider and discuss the withdrawal. Don't stop it immediately. Then you may consider and discuss with the patient the drug should be withdrawn or not. The reason being that the withdrawal, for example, if there are 100 patients, attention please, 100 patients, you put all of them on the drugs, 80% will be well controlled. Out of those 80%, after 2 or 3 years, if you pull out drug from all of them, half of them will again develop seizures. And developing again seizure is a very big problem. Let me tell you why. It has some very important implications. Let's suppose I'm an epileptic patient. You have diagnosed my epilepsy today. I had few attacks previously, and today you put the diagnosis on me. You're putting me on the drugs. First of all, my driving license will be suspended. You have to advise the patient to report to the driving license authority and document that thing and record that thing, that you have advised that. Is that right? His license for driving is no more there. Usually in the West, licensing authority says if you are epileptic and you are on drug, you may be having restoration of your license if you remain 2 to 3 years free of seizure. And let's suppose for 2 years I remain free of seizure, and for 2 years I was very regularly taking drugs and never got any attack. I'm about to get my license back. You stop my drug, 50% chances attack come back. For next 2-3 years again I'm banned for the license. So it was better to keep on the drugs. And while I'm on the drug, if 2-3 years I don't have any attack, I can get my license back. So there are many practical implications related with the withdrawal. Just knowing the drug is no art. The thing is that how intelligently you start the drug and how you handle the patient with drugs. Is that right? How you really handle the drugs in the end. That you start the drug, make the patient seizure free, keep him seizure free for a long time, and before withdrawal, discuss with the patient what are the implications. One implication is driving license, other implication is social implication. For example, someone got 2 seizures, he got an anti-epileptic drug. For 2-3 years, he didn't have any seizure. Right? If he continues the drug, most probably he won't have seizures again. Is that right? But if you withdraw and if he gets seizure again, there are social implications. All of us, unfortunately, still stigmatize the patient with the epilepsy. Then professional implications. There are certain professions which are barred. If an airline pilot develops epilepsy, his license is gone forever. Bus driver, truck driver, his license is gone forever. For personal car driver, yes, you can get it back, but you have to show that for such a long time you have been free of seizure. So due to these implications, it's very important, don't overdiagnose the epilepsy, don't underdiagnose the epilepsy. And once you hit the diagnosis, right, discuss all the issues with the patient, and then you go with the drugs. And you must know what is the art of introducing the drug. I will tell you what are the important points, and what are the art of withdrawal of the drug. This is almost artistic work. First of all, when a patient comes with epilepsy, you must know, if you are going to put him on the drug, you must know first of all, which is a first line drug for that particular epilepsy. I told you if patient has partial epilepsy, what is the first line drug? Carbamazepine. And if patient has generalized epilepsy, what is the first line drug? Valproic acid. If patient has absence seizure, what is the first line drug? Right? And if patient is having multiple epilepsies, some patient unfortunately have multiple types of epilepsies, what you will do? Valproic acid. You will put valproic acid. Now first of all, when a patient comes to you, you must find the first line most appropriate drug for that particular patient. Now let me tell you how we really start the thing. Let's suppose this is time, right? And here patient diagnosis has been made. Let's suppose you start with the drug A. There is valproic acid, for example, in case of tonic-clonic, you start with drug A. Now what really happens, you start with the low dose and gradually you build the dose. Gradually you build the dose. How long you will keep on building the dose? Let me tell you, this is the suppose therapeutic concentration, and this is, you can say, toxic concentration of the drug in the blood. Now, you start at the low dose, introducing the drug, and gradually build the dose over a few weeks. Now, how long you will keep on building the dose? Yes, please.
Until side effects appear.
No, until seizure disappear. This is the first thing. For example, you start on me, my seizure disappear, but you keep on building the dose until I develop the side effect. Who will call you an intelligent person? First thing is that you keep on building the dose until seizure disappear. For example, my seizure disappear here. Seizure disappear. You maintain the dose on this. And no need to change the drug. Because there's a basic rule in epilepsy. One patient should be, you should do your best to control on one drug. Because there are many drugs available, one patient should be controlled on, preferably on one drug, preferably by one doctor in charge. Not different doctors managing the same patient. Because one doctor knows what he has tried, what has worked and what has not worked. Now listen. Number one choice is, you start the drug, seizure disappear. Fine, no need to change the drug. you continue with that. Number 2, seizure continue, you keep on building the dose until maximum recommended doses have been given. Even if side effects are not there, but every drug has a maximum recommended dose. You achieve that and still seizures are not controlled. Maximum recommended dose, let's suppose, is here. We have achieved it. Even though yet side effects are not there. Recommended maximum dose has been achieved. Seizure could not be controlled. What will you do immediately? Yes, please. You will change the drug. You will stop this drug or not stop this drug? Yeah, the most important point is don't stop this drug. Because sometimes if you abruptly stop one drug, so severe seizures may come which may not be controlled by the next drug. So, maximum recommended doses you maintain this and then you have to introduce the second drug. Or in third patient, for example, these are 3 patients. In first patient we tried first drug, seizure controlled, no problem. In second patient we were building the dose, but maximum recommended doses are achieved, but seizure are not controlled. This is a problem case. She was a case in which we were building the dose, seizure were not controlled, but unfortunately side effects appear. Again, that is also a problem case, challenge for us. So these 2 cases are clinical challenges in which first drug with maximum dose could not handle the patient, or in which what really happened? Side effects started. In both cases you will not stop, not mean capital, not stop the drug immediately. In toxic doses, slightly reduce the dose. So what you really do, maintain the drug at lower level, right, and you start the second drug, second most appropriate drug. I told you first most appropriate drug for the partial seizure was carbamazepine and second line drug was valproic acid. So if it is partial seizure, you have tried the carbamazepine, it could not manage, you will start valproic acid. Gradually you will build the dose. By the time valproic acid come into mid therapeutic range, you start decreasing the dose of the first drug. When second drug reaches its concentration to mid therapeutic range, it means you are assuming that second drug is having a control over the disease. Only then you start withdrawing first drugs. Then you try, patient remains on single drug. This time onward patient is only on the second drug. First has been totally withdrawn. Now, there are again 3 options. Either seizures are controlled, very fine, or unfortunately still seizures could not be controlled. It means if seizures are controlled, proper thing. But if seizures are yet not controlled, what will happen? You will keep on increasing the dose of the second drug until its maximum recommended dose and still it could not control. It's a problem case for us, challenge case for us. Or seizures were controlled, but with that there is a toxicity. Still it is a problem case for us. It means second drug has also failed. With the same artistic way, you will introduce a third drug. What? You start the third drug, take it up to mid of the therapeutic range and start withdrawing the, tapering the second drug. Try to maintain the patient on third drug. Is that right? And again the same thing. Either seizures will be controlled or toxic side effects will appear or maximum recommended doses will achieve. Now in this fashion, Americans say that you have to try one by one all the next line drugs. Maybe sometimes you have to try singly 3-4 drugs. They say every drug, first line, second line, third line for a particular patient, every drug should be tried at its maximum recommended doses or tolerable doses. Most of the patient, eventually on any one of the single drug, patient will be controlled. But if all of them fail singly to handle the patient, only then you think of combination therapy, that one patient maintained on more than one drug. Is that clear? Or very rarely, even if multiple drugs cannot manage the patient, then you think of that surgical maneuvers. For example, some people go for temporal lobectomy, some people go for corpus callosum fissurotomy, right? But these drastic measures are rarely needed. And of course, in this management, there is no fun in telling you that you have to remove the underlying cause. If there are metabolic disturbances or there are structural lesions, they should be appropriately managed. Now, the second thing, once patient is taking this drugs, you have to watch for the side effects, right, over the time. In the end, let's suppose your patient is free of seizure for 2 to 3 years. Now the question arises, should the drug should be withdrawn or not? Who will make the decision? Patient will make the decision, but you will inform and provide all the data so that patient can make a wise and proper decision. Scientific data should be provided by you. Now, first you should tell the patient that on average, every second person in which we stop the drug, seizures start again. And usually it is difficult to guess that after a withdrawal of the drug, who will really remain seizure free and who will get the disease again. But recently they made some data that there are certain patients in which it is relatively safe to withdraw the drug and patient may remain free of the disease. For example, it is safe to withdraw the drug in patients in which, number one, there was adult onset, yes, adult onset epilepsy with underlying cause which has been managed. It means when you will withdraw the drug, the underlying cause has been removed, hopefully patient will remain seizure free. Number two, patient with normal IQ. Usually when you withdraw the drug, they can tolerate this thing well. Number three, normal mean they are not mentally retarded, because many patients who develop epilepsy with mental retardation because of multiple lesions in central nervous system, so it's better to give them drug for lifetime. Number three, patient in which EEG is normal, because if a patient is well controlled on the drug and there's no seizure clinically, but EEG off and on become abnormal, it's better not to stop drug. Is that right? So in which patient you would like to stop? In which 2 to 3 years seizure free is there, then you discuss with the patient, tell them all the pros and cons, right, and then you attempt to withdraw the drug, right. And when you are doing the withdrawal of the drug, you will not withdraw suddenly, you will withdraw it gradually. And again, when you are withdrawing the drug, let's suppose patient has already got his license back. When you are withdrawing the drug, during that phase, again driving is banned for 6 months. So many patients, especially in America, they prefer not to go off the drug. Is that right? Due to job implications and driving implications. But anyway, it will be informed choice of the patient, not doctor's decision. Doctors should just give the information to them that so many years you have taken the drug. Another question. If a patient has taken drug for 2 years and for 2 years patient has been free of seizure and yet drug has not been stopped and one day patient gets seizure, what do you think? Again you have to keep on giving the drug until you get more 2 years seizure free. While I'm giving this example, I remember one of the house officer who was working with me, she was on anti-epileptic drugs and one day she was very happy, it's 2 years completed and I never got a seizure, so my drug will be tapered off. And doctor told her that don't withdraw now because her father's Barsi was coming. So doctor said you will be under mental stress. After your father Barsi has gone, after 2-3 months we'll start withdrawing the drug. But unfortunately on the day of Barsi she again get seizure. And then of course she has to take drug for 2 or 3 years more. So you understand what are the delicacies of management of epilepsy? It's not enough just to know the names of the drugs and doses of the drugs. You must know how to use them intelligently and wisely. After that, now anti-epileptic drugs and females. These are some special issues. Number one, for young female, that as I told you, some drugs should not be tried. As I told you, one of the drug was phenytoin sodium, because there are so many reasons. I told you facial coarsening is there, gingival hyperplasia is there, hirsutism is there, ataxia, so many problems with that. Secondly, especially phenytoin and carbamazepine, they do induction of liver enzyme which are handling the oral pills, estrogen. So females who are on oral pills, if you put them on the anti-epileptic drug, especially carbamazepine, that will induce the enzyme and oral pills will be catabolized very rapidly and she may become pregnant inadvertently. So what should be your advice? Not to take drug or what?
Use some other barrier method.
Yeah, that's very good. that one thing is that she should either use a drug like valproic acid, which does not interfere with oral pills, or increase the dose of the oral pill, high dose estrogen, or use some other contraceptive method, number one. Number two, in the females, second issue is related with the fertility. That they say that females who are on the drugs, anti-epileptic drug, every third female has abnormal menstrual cycles and fertility problem. Probably most commonly it is due to valproic acid, right? So usually they have less chance to be pregnant as compared to the other females in community. But if they do get pregnant, then again you have to be careful that many of these drugs are not safe for the product baby, for product of conception. I told you Fanatic produces a lot of teratogenic action and babies born are very, very abnormal, right? So what should be then choice? If a female is on anti-epileptic drug and she becomes pregnant and she decides to continue her pregnancy, you will stop the drug or you will continue with the drug?
Continue the drug because it is more harmful to stop the drug during pregnancy. It enhances the seizure, but for
Those really decisions are not that simple. Hold on. You may continue the drug, may be right answer. For another patient, change the drug may be right answer. In some other patient, stop the drug may be right answer. Again, first see what is the situation of the patient. For example, if patient has been free of the seizure from last 2-3 years, and patient is had well-defined underlying cause which has been managed, so it's better to take risk of withdrawal. Is that right? But if a patient has a very difficult control of seizure in the first place, it's better to continue with the drug but change the drug with a relatively safer drug. For example, best drugs, the safest drug, the anti-epileptic drug during pregnancy is, my students should know that, which is the safest drug, yes? Phenobarbital or diazepam. There's no reported case of intrauterine abnormalities with clonazepam or other benzodiazepines or phenobarbital. Right? The modern drugs which are coming like lamotrigine or gabapentin, it's better to avoid them because yet we don't know what are their effects on the products of conception. Right? Third thing is that female should be given heavy dose of folic acid because folic acid helps the baby to multiply its cells normally. Right? Another thing which is important is that in last days of pregnancy, female mother should be, pregnant lady should be given vitamin K. Heavy doses. You know why? Because many anti-epileptic drugs block the transfer of vitamin K from maternal blood to the baby blood. So usually baby blood becomes deficient in vitamin K, and vitamin K dependent coagulation factors are deficient in baby, and after the birth baby may develop hemorrhagic disease. So to prevent that, you have to give heavy doses of vitamin K to the mother, right? And after that, yes, after that, you have any question to me? We have already discussed in detail status epilepticus, management of that. Did you have any question? Okay, the class dismiss.